All right, good morning, everyone. Welcome to the March hybrid meeting of the Southside Wellness Coalition. Want to go ahead and get started and share the agenda for the day. Here we are. Alrighty, so on your screen should be the agenda for the day. All right. As you can see, we are going to be approving after introductions 2 sets of minutes because we did have an abbreviated February meeting. We want to go over both January and February. And then you can see we have a presentation this morning by Allison Byrne from Veteran Affairs. And then Shelley Clary is going to talk about National Poison Prevention Week. And then, of course, lots of announcements about various up and coming events that we're supporting. I didn't make a list of them. Rather, I'm going to talk about, I have flyers in the room, flyers online, just talk about lots of the exciting events that are coming up, and of course, as well as the trainings too. And then I want to hear from you guys for member announcements, of course. All right, with that being said, all right, why don't we go ahead and popcorn around the room and get introductions. I can make sure I have everybody noted, and I'll start with Elena.
Good morning. I am the co-chair of the Southside Wellness Coalition. I'm also the housing case manager here at Tri-County Community Action Agency. And I will popcorn it to Amy Trent.
Okay.
Amy, I didn't hear you.
Why unmute this?
I see her microphone on, but it's not coming through.
Can you hear me?
Yes, I heard that.
I'm Amy from Legal Aid Society. And can I popcorn it to my left?
Who's to your left?
Um,
I think her microphone's dragging, Elena. You want to help her out?
Sure. Let's go to Barbara Johnson.
Good morning. My name is Barbara Johnson. I'm a community health worker with the Virginia Department of Health, representing the Southside Health District, which is Halifax, Mecklenburg, and Brunswick County. And I'm going to popcorn it to Shelley Clary.
Good morning. My name is Shelley Clary, and I am the education specialist at the Virginia Poison Center at VCU Health, and I will popcorn it to Allison.
Hey everybody, I'm Allison Byrne. I am the Community Engagement and Partnership Coordinator at the Central Virginia VA Healthcare System. That sounds like a mouthful. I will popcorn it to Elizabeth.
Hi, good morning. My name is Elizabeth Kopp, Community Engagement Manager with Girl Scouts Virginia Skyline. The area I serve that your coalition covers is Halifax County. Thanks.
And who would you like to popcorn it to?
Let's popcorn to April. Not sure if she can come off mute. Looks like she might have gone away.
Uh-oh.
Let's pick Oliver instead.
Hi, can you hear me? Yeah, hi. My name is Oliver, and it's a pleasure being here.
Alex, would you like to go next?
Sure. Hi, everyone. Sorry for no camera. I'm in the car right now. But I'm Alex Adler. I'm the Virginia Partnership Development Manager for Groups Recover Together. And I'll popcorn it over to Amber McGee, who's also with Groups.
Amber, Operations Coordinator with Groups Recover Together, also EMT firefighter and patient transport in Halifax. And I'll popcorn to Brenna.
Good morning, Brenna Link, Population Health Manager at the Department of Health for Southside and Petunia Danville Health Districts. Trying to think who hasn't gone yet. Allison, have you gone?
Yep, I went.
Dominique?
Good morning. My name is Dr. Dominique Watson. I'm a Halifax community member.
Jessica, would you like to go next?
Hey, I'm Jessica. I'm the clinical funding specialist for Southside Behavioral Health.
Is there anyone else who hasn't gone?
Yeah, Brian?
Good morning, everyone. Brian Price with the Virginia Rural Health Association.
We did not have an introduction from Tina Fulford. I think she might have a couple people.
I don't see her.
Okay, I don't see her either anymore. All right, with that being said, let's move to, thank you all for the introductions. Let's go ahead and go over the minutes that need to be approved. Let's see, we'll start with January. All right, so on your screen are the minutes from January the 16th. Again, members present, members on the Zoom, focusing on Liam welcoming the new leadership team, making plans for the CAD Committee Academy, making plans for Trauma Informed Care Network, the veteran outreach, and then lots of member updates and lots of training announcements. So a good meeting had back in January. Any questions, concerns? We need a motion to approve the minutes.
I motion that the minutes for January be approved.
I'll second.
All right, thank you. And awesome. All right, stop share on that. And then I'm going to bring up February minutes, which, as you guys recall, were very, very brief because we had supported funding for folks in our area to attend the virtual Creating Trauma Sensitive Schools Conference, which lasted for 2 consecutive days, the 20th and the 21st of February. So just to make sure that we were online with what we want to do every month, I think our meeting was less than 5 minutes. Certainly appreciate all of you that came that day. And I was a little bit, I felt bad a little bit. I was like, oh no. So we very quickly, of course, talked about announcements. We were in a snowy condition as well. So I was interneting from my home in a snowstorm, so I was excited that it even worked. But then, of course, we briefly discussed a couple of things, and then we chimed off because, of course, 54 local folks, which included many coalition members, went to the virtual Creating Trauma Sensitive Schools conference. So we were super excited about many of you taking a break from that conference for about 15 minutes to briefly meet and talk about upcoming events. And so again, here we talked about up and coming events, and Christine shared information about what the Trauma Informed Care Network is doing, all kinds of great stuff and up and coming trainings. All right, if we have any questions, concerns, we need a motion to approve.
I'll move to approve.
Okay.
I'll second it.
I didn't catch, who said the second it?
Skylar.
Skylar, awesome, thank you. Oh, thank you for joining us. Awesome. All right, and then back to our agenda. I have made Allison co-host, and she is making our presentation today. Welcome, Allison, the floor is yours.
Perfect. Thank you. I am going to go ahead and share my screen. I won't have, because I'm in presentation mode, I won't be able to see the chat, but I will go back to it like at the end if anybody has any questions. Happy to address those. Can you guys see that okay?
Yes.
Okay,
Yes.
perfect. Thank you. All right. So again, welcome or thank you guys for having me. My name is Allison Byrne. I am a community engagement and partnerships coordinator. I actually work with the suicide prevention team at the Central Virginia VA healthcare system. And so today was just going to talk a little bit about our VA suicide prevention annual report. Every year, our National Office of Mental Health and Suicide Prevention puts out a report just looking at the data around veteran suicide so that we can inform ourselves about how better to prevent it. So I'm going to get into some of kind of the higher level stuff, and then I'll talk a little bit more about some of our state level data as well. And then, of course, talk about some of the interventions that we are looking at, both from a level of like the hospital, but also what we can do in our communities to help prevent veteran suicide. So excited to share with y'all.
Your share screen, oh, there it goes. Never
Is
mind.
is it going now?
Yeah, it went, okay, yeah, it went,
Okay,
sorry.
perfect. Kind of some of the high level data. So every year we look at the data from like 2 years back. So the most recent full year data that we have on veteran suicide is actually from 2022, but came out in 2024. So just wanted to preface that at the beginning. When we look at the non-veteran adult population in the United States, in 2022, we had 41,484 suicides, and then the veteran suicide number in 2022 was 6,407. So obviously, these are both really big numbers, and this is a major public health issue. And the graph below shows the trends, the data trends from 2001 when they first started tracking the veteran suicides at a national level, all the way through 2022. So although over 6,000 is a very huge number, and ultimately our goal is to get that number down to 0. It is actually lower than 12 of the last 14 previous years for veteran suicide. So a lot of times when we talk about different populations, when we're talking about suicide statistics, that kind of high level total number doesn't necessarily give us the best information to be able to kind of compare and contrast. So we talk a lot about the rate, the suicide rate per 100,000. So when you compare the non-veteran adult suicide rate, which is 17.1% in 2022, to the veteran suicide rate, which was 34.7% per 100,000 in 2022, you can really kind of compare apples to apples and see that veterans had a much higher suicide rate than adults in the general population. That breaks down to about 31 adult suicides per day in the United States in 2022. Of those, about 18 of those were veterans. And so then when you look at whether or not those veterans were receiving any health care for the past 2 years at the VA, about 7 of them were, and then about 11 of them did not have any VA health care within the past 2 years prior to their death. So we know that there are so many veterans that we aren't necessarily able to reach, like in our buildings. They don't, come through our 4 walls of the VA. So that is part of why my position exists, and other outreach positions exist in the VA, because we know that there are so many veterans in the community that we aren't even necessarily identifying. And so being out there in the communities, identifying these veterans, and then providing them with resources, with tools, and the communities with resources and tools is really one of our core initiatives as far as VA suicide prevention. So when we talk about suicide, obviously an extremely heavy topic, an extremely big public health issue, can seem very overwhelming. One of the things that the reports does that I appreciate, and I think it's helpful, is that they identify anchors of hope. So looking for places, populations maybe, where we have seen some substantive and positive decreases in suicide rates. So one of the big areas that we saw in 2022 were the rate of female veteran suicide. So we saw that between 2021 and 2022, the age-adjusted suicide rate for female veterans decreased 24.1%. When you look at general females in the adult population, their suicide rate actually increased 5.2%. We also saw some substantial decreases in firearm involvement in female veteran suicide deaths, and also suffocation involvement in suicide deaths among our female veteran population. And overall, the age-adjusted suicide rates for female veterans that were receiving VA health care within the past 2 years declined by almost 30%. We saw a much smaller kind of difference in the male veteran population. We saw age-adjusted suicide rates increased 1.6% between 2021 and 2022. For male non-veteran adults, the rate increased 1.8%. So that obviously an increase is an increase, but the male veteran rate was increasing at a slower rate than the general male population. One of the things that we know through years of data collection and research is that veterans that have a history of military sexual trauma are at elevated suicide risk. We saw a decrease in the female veterans that died by suicide with MST diagnosis of about 18% in 2022, but we saw that male MST population suicide rate shoot up a lot, almost 38% in 2022. So that kind of data helps us really target, you know, how we can better intervene with certain populations, and what we can do moving forward to make sure that we are really identifying those veterans at elevated risk, and that we're offering them appropriate resources to help them stay safe. Another area in which we saw decreases in suicide rates among veterans in 2022 were among our younger population. So that age 18 to 34 population, we did see a decrease of about 4% in 2022 in their suicide rate. Also, age 35 to 54 0.1% decrease. Any decrease is, is good, but obviously much less substantial than the younger veterans. And then on the other hand, we did see increases in our older veteran population. So those veterans that are age 55 to 74, we did see a 4.4% increase, and veterans that are age 75 and older, we saw almost a 5% increase. So again, just using that information to make sure that we are identifying maybe some of the risk factors that are present for older veterans that may not necessarily be as present for younger veterans, and they have different challenges too. And so looking at longer term trends, so this isn't so much year over year. This is measuring from 2001 when we first started keeping the data to 2022. We have seen significant increase or decreases in suicide rates for people that have diagnoses of anxiety, PTSD, depression, and alcohol use disorder. We've seen pretty big declines over time. So that is really great. Another place that we've seen an increase, though, are veterans with maybe more specific mental health conditions, veterans that have psychotic conditions other than schizophrenia and bipolar disorder. We have seen a sharp increase in their suicide rates, as well as veterans that had sedative use disorder. There has been an increase there as well. And another one of our target populations, veterans that are unhoused, and also veterans that may have involvement with the justice system. So the VA has a pretty robust service in terms of helping veterans with housing. In 2024, over 46,000 veterans were housed with help from the VA, which I think is wonderful. And it's not just the VA, it's collaborating with our communities as well. So we have a housing first model that we use in the VA, and that's evidence-based. It's grounded in doing outreach. It's grounded in getting the veterans housed and then providing support so that they're able to maintain that housing. We saw a 19% reduction in suicide rates among veterans with a homelessness diagnosis in 2022 from the previous year, which is really substantial. We do know, though, that being unhoused, having a history of homelessness diagnosis, and also having justice system involvement, all of those are risk factors for suicide. And so you can see in the graph all the way to the side that shows the homelessness diagnosis. Veterans with a homelessness diagnosis is that top red line, as compared to the suicide rate with for veterans that don't have a history of homelessness diagnosis. And then the bottom graph shows veterans that are involved with, we have a program called VJO, Veterans Justice Outreach. So veterans that are involved with the VJO program have a much higher rate of suicide as opposed to veterans that are not. And that was sort of the only metric that we had to use as far as like VJO involvement. We know that they have justice system involvement, and it's the justice system involvement that is the risk factor there. Another focus group, kind of subgroup that we focus on a lot is the transition period. So when a veteran is becoming a veteran, when they're transitioning out of active duty service, that can often be a really challenging time. There's often a loss of support, a loss of structure, maybe even a loss of sense of purpose, and there can definitely be pretty severe financial difficulties during that period as well. Frustration with filing for disability. There are a lot of different things that can come up. So we do see that our rates per 100,000, while they've fallen between 2021 and 2022, they are still substantially higher than that overall veteran suicide rate. In 2022, it was 46.2. So that we're looking at veterans who separated from the military service in 2021. And so we're looking at them over a 12-month period. So that is definitely a significantly higher rate. And then in the bar graph, you can see the breakout per branch of service, and you see that the Marine Corps, their rate was 67.9 per 100,000. So definitely we see a big increase in risk in this transitional period. And we're always trying to partner with other organizations and tailor our offerings to better identify veterans that are going through that transition period and offer them resources, and just making sure that even though there's a loss of support from active duty potentially, that they're feeling supported in other areas of their life. And as much as the VA can play a part in that, we want to be there to be able to do that and help them navigate the new systems that they're having to interact with. So looking at means used for suicide, this year, you can see that almost 75% of veteran suicides in 2022 were by firearm. That's the stat for this year. It's always high. I will say every year that I've looked at these reports, it's always been high. The majority of veteran suicides have been by firearm. When you compare the firearm use rates in suicide to the general population, male veterans are 69.6% more likely than male non-veterans to die by suicide using firearms. And female veterans, even though we saw their firearm suicide rate go down this over 2022, their rate was 144.4% higher than female non-veterans. We know that veterans may be more likely to have firearms in the home. They may be more likely to have unsecured or loaded firearms in the home. And so when we're talking about safety planning with veterans, we talk about firearms and safe storage a lot. The VA, we have given out 3.2 million gun locks, I believe, and they're free and we always have them. So if anybody ever needs them, please let me know. I'm happy to send them wherever they need to go. We just want to make sure that they're getting into the hands of veterans. Why it's so important to talk about safe storage is that we really want to delay access to lethal means during a crisis. So we know that securing firearms can provide a really critical time buffer in which those suicidal impulses may pass, they may get less severe, or somebody else could intervene. We also want to make sure that we're doing our part to prevent accidental injuries. When firearms are securely stored, it limits access for other family members, preventing accidents from occurring. And we just really want to encourage responsible ownership of firearms. So emphasizing that those secure storage practices can reinforce the importance of responsible firearm ownership within the veteran community. It's something that's very important to many veterans to be firearm owners. And so when we're working with veterans on safety planning, we want to make sure that we're being culturally competent and sensitive to that, and also taking into account their lifestyle and their values, and that it's a two-way conversation. It's not a clinician coming in and kind of telling someone, oh, you need to lock your guns up. That's not going to work. You really want to make sure that you are looking at what might work for that veteran's family, their lifestyle, their value system. So it's an ongoing conversation, ideally. So looking at Virginia, I told you a lot about the national numbers, but in Virginia in 2022, we had 184 veteran suicides. That is 9 fewer than we had in 2021. And our suicide rate per 100,000 in 2022 was 26.6 per 100,000. It is significantly lower than that national veteran suicide rate, but it is higher than the national general population suicide rate. And you can see this graph is a little busy, but it shows, breaks out from state, region, national, and then the rates state, regionally, and nationally. And as far as the means used in Virginia, we continue to see that trend of a much higher use
Uh-oh. Did I freeze? Did you all freeze?
Yeah, she froze.
She froze.
Yeah, I think Allison froze.
There she's on. She's still there. While we're waiting for her to come back, just some welcome in. I know Skylar joined us, Catherine joined us, Liam joined us. Welcome, welcome.
Sorry about that, Kenan.
Oh, you're fine. I was just welcoming you guys in.
Better late than never, right?
Right, that's right.
Hey, everybody. Good to be with y'all today.
Hey.
Good morning.
We have a great crew on today. Impressive. Good to see so many faces.
Awesome, awesome. All right.
I'm wondering if she knows she lost a connection.
Oh. She's still on from my end. When I can tell, some people have gone back and forth from the waiting room to the, and I've tried to figure that out, but she's not in the waiting room. She's in the room.
Maybe we can message her. Let me see if I can send her a chat.
Yeah, I did.
Oh, you did? Okay.
She's got, Shelley, can you hear me?
Yes, ma'am.
Okay, that's not that, okay. All right. Oh, that must be Lindsay challenging her as a co-host. Oh, and then she just went off. All right, so hopefully she'll be right back in. While we're waiting for her to scoot back in, I will say that flyer has not been approved yet. If you guys can go ahead and block your calendar for May 21st. We are hosting a service members, their families and veterans mental health summit at the Prizery in South Boston on May 21st. It's an all-day, one-day event. Harry, there comes Allison.
Hey, I am so sorry. My internet just dropped out of nowhere.
We're glad you're back.
I was just talking and talking.
You're back as co-host.
I'm sorry.
You're back as co-host.
Okay, perfect. Did I leave off? Was it here?
Yes.
Okay.
Exactly.
Okay, perfect. I'm so sorry about that, y'all. Technology. But so I think I was saying that yeah, our state level data bears out that we see a much higher use of firearms in veteran suicides than we do in the general population. And yeah, we saw that it's the suicide rates by firearm are relatively stable for the past few years, but still much higher than that general population. And then a quick reminder about lethal means safety. So they did a study of about 300 people that had survived a suicide attempt and asked them, from the time that you had the thought to take your own life to when you went to go obtain that lethal means to take action, how long did it take? And for the vast majority of them, over 75%, it was less than an hour. And then a substantial minority, almost 50%, was less than 20 minutes. And then about a quarter was less than 5 minutes. So we know that secure storage of lethal means, whether that be firearms, whether that be medication, can just help put time and space in between those thoughts and having the access to lethal means. And then just looking at the fatality of firearms, which has a 85 to 90% fatality rate versus every other method combined, which is about 5%. We see that with firearms, there is just an extra impetus because they are so fatal in suicide attempts to really make sure that we're having those discussions about secure storage and lethal means safety. So what do we do with all this information? I just threw a lot of numbers at you, a lot of percentages and rates. So what does this all mean for what we do going forward? So there are 7 key areas that the VA has identified that we're going to focus on as far as suicide prevention. So those are promoting secure firearm storage, building and sustaining community collaboration so that we're able to outreach veterans that don't necessarily kind of come into our milieu as a medical provider, expanding crisis intervention services, tailoring prevention and intervention services to the population, advancing suicide prevention into non-clinical supports, and enhancing mental health care access across the full continuum of care. And lastly, integrating suicide prevention within medical settings. So a few kind of recommendations or what some of those things might look like on the ground. When we're talking about veterans who are unhoused, veterans who are justice involved, or maybe veterans who are new veterans, they're transitioning out of active duty military service. Some of the things that anyone can do really are to help connect veterans with job search or skill building resources. We know that that transitional period, especially can be really challenging financially and also in terms of finding a skills fit. Like I did this in the military. Not every position that somebody does in the military is going to have like a 1-for-1 kind of match in the civilian world. So we have a website that talks about vocational rehab services that we offer, also just general career and employment information that can be helpful to veterans. Considering connecting veterans with a healthcare for reentry veteran specialist who can provide resources and direct veterans to community or legal assistance. That's for justice involved veterans. They also have the Veterans Justice Outreach Program. They work with a lot of like the veterans dockets and other criminal justice partners to help connect veterans with resources. We do have the National Call Center for Homeless Veterans that is a lot like the Veterans Crisis Line. It's a 24/7 line. They can be reached at 877-48-VET. They are for veterans who are experiencing homelessness, though. So they're like Veterans Crisis in that they're always available and that they can refer back to the home VA for their homeless team to follow up with the veteran and find resources, but them being available 24/7 is nice, just so that they can help with veterans who might be in crisis due to their housing concerns. For older adults or maybe adults that are toward end of life, we want to just make sure that we are assessing, we're monitoring, we're treating veterans for suicide risk, or monitoring those suicidal ideations if they exist, and that we're developing safety plans, but also incorporating people that are close to the veteran. So families, caregivers, realizing that no veteran lives in a vacuum. We want to make sure that we are enlisting those supports to help reinforce the veteran safety. Screening older adults for lethal means access and providing means safety safety counseling and resources. I also have pamphlets on mean safety counseling that the VA prints out, or you can print them out yourselves if anybody's interested. I'd be happy to share the PDF. We can screen older adults who have been through a life-threatening accident or illness for suicidal ideation. They may be at elevated risk. Often we find that conditions that change a veteran's level of functioning or maybe like manner of functioning, those veterans can be at increased risk for suicide. So we just want to make sure that we are continuing to screen older adults and not just kind of saying, oh, well, it's their age and, it makes sense that they're feeling this way. We want to make sure that we are adding support to older veterans as they have a different type of transition. So not necessarily the transition from being active duty to becoming a veteran, but more transitions out of the hospital if they are transitioning into a rehab center or nursing home or out of every kind of level of care transition. That can be that can potentially be a risk factor. So we just want to make sure that we're monitoring especially closely during those times. Access to mental health services. We just want to make sure that we're connecting veterans with information on how they can obtain same-day mental health services. There is a website that is linked to this presentation, and I can send it out to you all if you're interested. They're also in most VA clinics, they have a same-day access mental health clinic. And so veterans during regular business hours are able to walk in and be seen by somebody immediately for mental health. And of course, there's the emergency department, which never closes. So veterans are always able to go there in mental health crisis as well. You can save the Veterans Crisis Line number in your phone and share that, spread the word throughout your connections in the community and veterans that you may know. That's 988, then press 1. And then linking veterans to information about the mental health and substance abuse resources available to them. There is a website called Coaching into Care that is a really good place to start if you're a family member or a friend of a veteran, and you can learn about resources and how veterans can be referred to those services locally. For medical settings, we want to make sure that we're checking in with veterans who are struggling with medical conditions, including chronic conditions or newly diagnosed conditions. Again, that transition, that change in functioning can be a risk factor. Encouraging connection to additional support methods. We have a really great program called Whole Health, where it's more of a mind, body, spirit emphasis, kind of a departure from the traditional medical model. They have everything from Tai Chi to acupuncture to aquatherapy that's available through that program. So they do an assessment with the veteran and really try to figure out what the veteran's values are, what they value in life, and those goals are really tailored toward the veteran living in accordance with their values. So that's an option. We also have a suite of mobile apps that are available on like any kind of phone or tablet. They cover everything from like tips on how to get better sleep to strategies on how to manage PTSD symptoms. So there's an array of mobile apps that are available. And the good thing about that is veterans can obviously access them anytime. They don't have to wait for an appointment or anything like that. If you work in a community care setting, we just want to make sure that we're promoting those discussions about secure storage, about lethal means safety. I also have a lethal means safety toolkit that I can distribute to community providers. We want to make sure that because many veterans don't get their care at the VA necessarily, we just want to make sure that all clinicians that see veterans or medical providers have the tools to have those discussions. There are also trainings that you can take that some of them give CEUs, and the ones that I linked are all free. So everybody loves free CEUs. And also you can always ask for gun lots and be able to distribute those or even keep them in the waiting area so that veterans are able to just like pick one up and go and not even necessarily have to have that conversation if they're not interested in doing that. preventing veteran suicide. We do have a public-facing website that goes over a lot of the data I touched on today and more, but it does a really good job of connecting. Here's the data, here's the strategy that we're going to pursue, and then later on, sort of here's how that strategy is going. So I think it would be a good place to continue to visit if you're interested in this issue, to kind of check in on how some of those strategic plans are going. And lastly, just want to remind everybody that collective effort really does make a difference. We all have a role in preventing suicide, whether you're a community member, whether you're a family or caregiver. You can recognize those signs. You can just offer a safe space for a veteran to talk, and normalize having those conversations about mental health. And then just knowing the resources, right? So there's the Veterans Crisis Line. There is Don't Wait, Reach Out, which is sort of a peer-to-peer resource. Veterans can log on and hear stories of veterans that have had maybe similar challenges and have overcome them, what they did to overcome them. There are also veteran service organizations that play a really, really big role just in creating public awareness, collaborating with VA to improve access to mental health care and healthcare in general, really. Educating the public on the challenges that veterans may face and spearheading outreach initiatives. Congressionally, we want to make sure that we're advocating to sustain support for funding for suicide prevention programs, expanding telehealth access, because a lot of veterans who don't necessarily have transportation to the VA may be more likely to engage in telehealth and get their care that way. And we just want to make sure that we're able to cast a wide net and we're not leaving people out just by virtue of where they may live or what access to transportation they may have. As far as the media goes, it is important to cover stories about veterans' challenges, even about suicide, but also about messages of hope. The link that is in this slide talks about how to responsibly cover at a media level stories of suicide and how we can promote normalizing the conversation without promoting or kind of glorifying the act of suicide. So there are a lot of good tips in there if you're interested in that. And then, of course, veteran to veteran can be a really powerful connection, peer to peer, and just being able to check in with one another, to kind of meet one another where they're at. If they've had similar experiences, it can be a really powerful thing to connect on that level. So I just wanted to reassure everybody that's here. Obviously, you're here because you care. Every effort does make a difference, and together we can help create a compassionate and supportive network where veterans are feeling empowered, they're feeling hopeful, and that they know that help is available. So that is all that I had before my thing times out again. Any questions? I'm gonna look at the chat really quick. I think I lost it all when I fell off. I'm sorry.
Hey, Allison, it's Liam. Thank you so much
Hey.
for this.
Yeah, no problem.
Sorry if I'm a little shaky. I'm traveling, but I was thinking on the homeless services side of things. A lot of times when we do, I would say 99% of the time when we do intakes, we don't do a suicidal assessment or a suicidal ideation assessment. But then, when we put folks into an apartment that they've never been in before, maybe in a community that they've never been in before, it really exacerbates those feelings of isolation. Do you know if there are any sort of suicidal ideation screenings done prior to someone entering the homeless system? Like, would they be done at discharge or anything like that we could maybe send over with the intake stuff?
So at the VA, I know they do a Columbia screening with the initial, like the initial intake for services, and they do them periodically at our in our homeless team services. I'm not sure exactly like what the interval is, but I would think that they would do them like before they move into a transitional housing as well. I'd have to ask one of the team members there, but that Columbia screen is pretty simple. You know, it's only a few questions, and then from there, if it's a positive screen, then you know, you can follow up, and we do something called the comprehensive suicide risk evaluation, which is a longer screener, and it includes doing a safety plan with them. But I think the Columbia screen is a great tool. I'd be happy to share that with anybody who's interested.
Yeah, that would be great. Thank you so much.
Yeah, no problem.
I would also definitely like to get one of those. This is Elena.
Yeah, no problem. I will send you guys an email because it'll probably take me a little bit to find the link. But yeah, I will definitely do that. Any other questions? I'm sorry my chat got completely erased, so if you had one in there before, I missed it.
I didn't see anything in the chat. Allison,
Okay.
if you don't mind following up, to send me your presentation as well as the Columbia screening, and I'll have Ellen put that in with the minutes and all the documents from the meeting on our website.
Oh, perfect. Yep, I can do that.
Thank you. Any other questions, folks?
I just had a question. This is Catherine. Great presentation, Allison. I appreciate it. When you talked about the suicide rates declining
Mhm.
in this between 21 and 22, was there anything that the VA started doing differently that would have affected that change, or do you not delve into that? Because I know y'all are into the stats, but I don't know if you go behind the scenes and try and figure out what you guys were doing differently or what the community was doing differently.
Yeah, you know, it's hard because suicide is like so multifactorial, right? It's hard to point to like one thing that, you know, oh, this we can say, oh, well, we increased this service and this might have had an effect. But it's hard to really like come to a hard conclusion with this type of data because it is so every suicide is sort of so personal and has like so many factors that you know, that go into that. So it's hard to say. I will say around 2021 and 2022 is when like my position was created in 2022. And I don't mean me, myself, like you know, I had a huge, you know, making the stats change. I don't think that, but nationally they finished the rollout of having CEPCs specifically. And so I think the longer that we have specific outreach positions to reach veterans that are not necessarily like coming to the VA. They don't necessarily have VA providers kind of, you know, putting eyes on them and things like that. I do think that that has the potential to really make a difference in the overall veteran suicide rate. So I know around 21 or 22 is when my facility was one of the last people to get this position, the CEPC position. So pretty much everywhere in the country had it by then. And so part of me thinks that maybe that community partnership, that like being out in communities has had some effect, but it's really hard to say.
Thanks for that. I appreciate it.
No problem.
All right, any other questions? All right, we're going to turn it over to Shelley Clary, who's going to share information with us about Poison Control Prevention Week. Thank you, Shelley. And you are co-host.
We share. Can you guys see that?
Yes.
Perfect. All right, so I am with the Virginia Poison Center, and we are through VCU Health, and this is National Poison Prevention Week. So Kenan had asked me if I just wanted to jump on and share a couple of things. So I just, oh, wrong. Oh, let's see. There we go. I just wanted to give you some information. So National Poison Prevention Week was established in 1961 by Congress. It is celebrated and observed every year during the third week in March. The purpose, of course, is to raise awareness of poison prevention and safety. And we like to give a big plug to the Poison Helpline. Just kind of play that up during the week even more. Our theme is when the unexpected happens, we're here for you with fast, free treatment advice by calling the Poison Helpline. And just some information on poison centers in general. So there are 54 poison centers across the country. We are fortunate to have 3 in the state of Virginia right now. And green is our area, so the Virginia Poison Center, and purple is the Blue Ridge Poison Center, and they are through UVA Health. And then the orange is National Capital Poison Center. Each center is certified as a regional poison center by America's Poison Centers. Poison centers are free to call. It's confidential. We're open 24 hours a day, 7 days a week, as an emergency service that assists residents and physicians. We get a lot of calls from doctors and nurses with cases of exposures to poisonous chemicals, venoms, vapors, or medications. We also answer tons of non-emergency questions about poisons and poison safety, so it doesn't just have to be an emergency for you to call the poison center. And when a person dials the toll-free number, it's going to call the nearest poison center based on your phone's area code. Cool. Why do poison centers exist? So just some numbers for you. So poisoning is actually the leading cause of unintentional injury death in the United States. Over 2 million human exposures were reported to poison centers in 2022. 40% of those occurred in children 5 years or younger. 93% of poisoning cases in the United States occurred in a residence. 67% of those cases were able to be managed on site where the exposure occurred. So our goal as a poison center is we want to be able to assist people in poisoning situations. We want to be able to manage as many of those cases on site as possible. And we want to be able to provide the necessary education in order to spread awareness to potential poisons and hopefully to reduce those future poisoning incidents. Just some data for you. So this is just for our poison center. In 2024, we actually received a total of 31,602 calls to our poison center. So this isn't the whole state. This is just our center. 28,525 were for humans. 391 were calls about animals, and 2,686 of those were informational calls. The box at the bottom kind of gives you a breakdown of where these calls came from. So like I said, our highest percentage of calls come from a residence. And then it kind of trickles down to workplace, healthcare facility, school, restaurants, public areas, and then unknown. A breakdown for 2024 for reasons of human exposures. So 22,182 calls were for unintentional purposes. So it could be environmental, it could be occupational, it could be therapeutic errors with medication, misuse, bites or stings, so snakes, spider bites, food poisoning. 5,019 were intentional, so suspected suicide, misuse, or abuse. 904 were adverse reactions. And then 420 were for other or unknown calls. The top 5 routes for human exposure poisonings were ingesting, of course, always going to be the highest. And then inhalation and nasal was second. And then you can see dermal, ocular, and then bites and stings followed. This gives you a breakdown of where these were managed when they came in. So 67% were on site, so they did not have to go to a healthcare facility. And like I said, our goal as the Poison Center is we want to help you manage it at home or wherever you are so that you don't have to go to an ER or an urgent care. 29% were at a healthcare facility or they were referred in once they called. 2% refused referral, and then 2% were unknown. So they were either lost to follow up or they didn't want to report what happened afterwards. Benefits of managing on site. So 24/7 fast, free, confidential expert advice from healthcare providers when you call the Poison Center. So when you call here, we actually have registered nurses that answer the phone. And then if it needs to go further, they will consult with pharmacists or doctors. It saves millions of dollars in unnecessary healthcare costs for the patient, and then allows more efficient and effective use of limited healthcare resources. A breakdown of age for our 2024 calls. So we had 10,885 of our calls were for kids 5 years and younger. And then you can see the next biggest chunk was 20 to 59 years old, which of course is a bigger age gap there. And then our 60 and older were 3,494. So of course, biggest cases for us are 5 and under, and then that 20 and 59 where you start taking more medicine, you know, errors in general with pesticide exposures, more work-related incidents. And then just some spring poison prevention safety tips. So when spring comes around, we start seeing more calls for cleaning products. Everybody is getting in that spring cleaning mode. So just a couple of tips. Make sure you're wearing rubber gloves to protect your skin. Always read the directions on the label and pay close attention to warnings about ventilating areas when you're cleaning. We get calls for people that close that bathroom door, they go in there and they start cleaning, and then they start getting shortness of breath, their throat is burning because they're not ventilating those fumes as they're cleaning. You don't want to mix cleaning products. So a big common mistake is mixing products that contain chlorine bleach with ammonia, ammonia-based products or acidic products. This produces chloramine gas, which is extremely irritating to the eyes and the lungs. The little chart over to the side kind of gives you a better idea of other products not to mix together. You want to keep products in their original container with the labels intact, and be sure that you're keeping cleaning supplies, including detergent pods, whether it is laundry detergent pods or dishwasher detergent pods. Make sure you're keeping them out of reach from children and pets, because aesthetically, we want to put them in these cute little containers and sit them on the counter, and it looks great, but it's easy access for kids. So just keep that in mind. And as you're pulling products out for spring cleaning, make sure you're putting them back after you're using them. Pesticides. With spring, we start the growing season. We also are outdoors more. So as you're using pesticides, make sure you are reading the entire label before you purchase it and while you're using it. And actually, you are legally required to read and follow everything on the label when you're using pesticides. When transporting pesticides, make sure that you put it in the truck bed separate from other people that are riding in your car, separate from your groceries, or from animal feed. Store it in a locked cabinet or a secure area away from ignition sources, food, or personal protective equipment. You want to keep those pesticides in their original containers or bags when storing with proper labeling. Measure and mix in well-ventilated areas away from children and pets. You want to wash contaminated clothing separate from other clothes before reusing them. And then dispose of leftover pesticides properly, including empty containers. A big call we get is it accidentally sprays in their eyes. It can get on the skin. Another one is you accidentally pull it out. It's in the garage. You forget to put it away, and pets, it's easy access for pets. When it comes to plants, make sure you're keeping all bulbs, seeds, plants, and flowers out of reach from children and pets. Know the names of all of your plants in your home, yard, and play areas. This is a big one. lots of calls for pets that take a bite out of a leaf or kids that grab them quickly. You would be surprised how many plants in your home can actually be toxic. So you always want to know the names for when you call us. Teach children to never put leaves, stems, bark, seeds, or berries in their mouth. It's always great to download a plant identification app on your cell phone in case of an emergency. And now Google has that neat feature where you can take a picture of it and it will tell you what it is. Don't assume that a plant is not poisonous because animals or birds eat them. This is a really big one. Never eat wild plants or mushrooms. Don't rely on cooking it to destroy the toxic chemicals in plants, especially mushrooms. So unless you are an expert mushroom forager, don't eat them. Buy them from the grocery store. Fruit pit seeds from apples, cherries, nectarines, peaches, they are poisonous, but only if chewed and eaten in really large amounts. And then resources from our poison center. So of course we have our website where you can order free materials. Kenan had some stuff there today for people that attended. We have magnets, we have brochures, we have stress balls, we have the pill minders. So if you ever need anything, don't hesitate to reach out. We have our social media outlets. And this week we've been posting tons of poison prevention information. And that is all I have for today, Kenan.
Thank you. And we do have those items here in the room. We have one person in the room, so that's awesome.
I like them.
Sarah loves them. Floor is open for questions. Oh, I see my chat box. Let's see. Okay. Amber says, was so thankful for this as a new mom around 2010, and my toddler ate holly berries. So I called scared and was educated that small ingestion shouldn't be harmful and what to watch out for. Thank you, Amber.
I had it one time at one of my old workplaces where one of my students told me that their child would just eat mushrooms, just like random mushrooms growing out in the yard. Because her mom always told her to eat her vegetables, so she thought that that was included as a random, and she went on like a whole like hallucination trip, had to go to the emergency room and everything.
Oh,
so
wow.
The whole mushroom thing is like, yeah, don't eat them.
Yes, we had a case, I don't remember if it was last year or year before, but they went out, picked mushrooms and were boiling them to put in a soup. And they thought that that would kind of kill off any toxic, and they were severely ill. So definitely a good reminder.
Oh, awesome. Thank you, Shelly. Any more comments, questions?
I loved all the data. That was really cool.
Yeah, two wonderful presentations today. Thank you all. Thank you very much. So moving down to announcements, pretty standard. I know that you see on our social media that we've got adult mental health first aid, which is next week. We have some adult mental health first aid coming up in April. We still have the Lunch and Learn Revives once a month. Next dates in the agenda, April 18th, May 19th, and June 3rd. We'll be announcing the second half of those trainings in the next month or so. Couple of things ongoing right now. As I mentioned earlier, at the end of Allison's while Allison was transitioning back into our meeting, I shared that we are working on a couple of conferences, which I know you all have seen on social media already. We are supporting, along with the Trauma Informed Care Network, the Overcoming Trauma Through Connection Conference that is being hosted in Danville. We are sponsors of that conference. The sponsorship is, the enrollment is open. People are registering. It does not cost anything to attend this one-day event that we are supporting. I'll roll down there if you want to kick the QR. Oops, the time I meant we're over top the QR code. If you wanted to click the QR code now, while that's up, please do so. It'd be a good day to learn lots of information about how to support local folks. We are certainly going to be sending this out to the folks as well that attended the virtual Creating Trauma Sensitive Schools conference. But it's on our social media. If you want a specific copy of that, please email me. I'd be glad to send you the digital copy so you can put it on your social media as well. All right, then where is the other? Hang on 1 second. Where's my, then of course, as I mentioned earlier, we are in the final stages of approving, where is it? Hang on, 1 second. Where is it? Hang on. Here we go. Oh, there we go. All right. Go back to share screen. Here we go. There we go. All right, so this is not on our social media as of yet. We're waiting for our planning team to approve it. It will be approved by Tuesday. This is the Service Members and Veteran and Families Mental Health Summit that we've been working with Danville, Pennsylvania CSB, Allison, her team, our team, to conduct this event. It's not live yet, but I want you guys to be the first to see it. That we're hosting this at the Prizery in South Boston as a regional event for our local SMVF families. It has never been hosted in our area before. It's been hosted further west from us for the last couple of years. So we're super excited that we were invited as partners to join this effort and host this. We also created a separate flyer that will be coming out as well, inviting folks to come and also be providing information about their services. So all of you on this call that provide services to the local area that is available for veterans, please, when you receive the invitation, the flyer on social media, register for the event as an individual, and then please let us know. Also register for us with a table inside the Prizery on May 31st. Any questions about that?
Kenan, is it important to let everybody on the call know that we need to have a really strong following? Because it has been given to us to coordinate and work with Pennsylvania on. So it's important that we get about 150 veterans there.
Yes, it's really, I thank you, yes. It's really important. We negotiated, we're very vocal about the fact that we've not hosted this in our area and that we have a great need to do so. So yes, if you all could individually reach out to anyone you're connected to, those SMVF families, veterans, active service, those in the National Guard, to attend this no-cost event that has breakfast, lunch, and lots of great information from our local community partners as well as our state partners as well. So yes, really important that we do that. Yes, we'll have flyers. Yes, absolutely. Once we get the approval on the flyer next Tuesday, we'll be sending it out digital form. We're also going to have some professionally printed. So yes, we're going to start a real heavy, about 6 weeks, Sarah's here, about a 6-week campaign to get everybody registered prior to May 21st, which is technically, well, basically 2 months from tomorrow. 2 months from tomorrow. And definitely hoping to get at least 150 there. Awesome. All right, so then the floor is open for other announcements. Member news?
So I have some updates from our recent COC meeting. So just so everyone knows, the continuum of care is the backbone of our community's response to homelessness. It's more than just funding, it's also a strategic network that's dedicated to ensuring that families and individuals have a clear pathway to stable housing. So first of all, Tri-County does now have a permanent supportive housing program. As a reminder, the permanent supportive housing program is designed for individuals and families who have experienced homelessness for at least 12 months within the past 3 years and have a diagnosed serious mental illness, disability, or substance use disorder. So if you know of anyone who you think may qualify, send them our way. We have very limited funding available for emergency shelter and prevention services in Mecklenburg and Charlotte counties. We are still exploring options to establish a homeless shelter in Southside. So if anyone has any ideas or thoughts about that, please let me know. And we are also brainstorming ideas for a fundraiser to support these efforts. I also have some updates for some upcoming events for Tri-County. The Infant Maternal Health Coalition Appreciation Brunch to celebrate World Doula Week will be March 26th at Pass Community Medical Center in South Boston from 10 to 12. We will be hosting a community job fair on Thursday, March 27th from 10 to 3 at Washington Coleman in South Boston. We will be hosting, or at least participating, in a maternal and child health summit. That will be Saturday, April 12th from 9:30 to 3:30 at Pass Community Medical Center. National Youth Violence Prevention Week is April 28th through May 2nd. April is also National Child Abuse Prevention Month, the month of the military child, and Sexual Assault Awareness Month. Tri-County will be hosting 3 events so far for Sexual Assault Awareness Month. We will be hosting a line dancing night on Friday, April 11th from 5:30 to 7 at Washington Coleman. We will be hosting a karaoke night Friday, April 25th from 7 to 10, also at Washington Coleman. And then we will be hosting Walk a Mile in My Jeans. That's Saturday, April 26th from 10 a.m. to 12 p.m., also at Washington Coleman. For those who aren't aware, Walk a Mile in My Jeans, there was a case a few years back where a woman who was sexually assaulted, when it went to court, the judge said that he didn't think that she could have been sexually assaulted because her jeans were very tight, and the assaulter wouldn't have been able to remove them without her assistance. So that's what we are commemorating.
Thank
That
you,
was on the
Elena.
26th, Elena?
Hold on, I just shrunk my window. Yes, that is Saturday the 26th from 10 to 12.
Also, just for all of you who know, the karaoke night's a blast.
It really is.
And I promise I will not sing this time.
I promise I will sing this time.
All right. Other announcements. Amber, I got your request for the Revive trainings. I will send you that in email today.
Hey Kenan, are we doing anything, or is the coalition doing anything for Drug Take Back Day in Southside?
For April 20th, nothing is planned at the moment.
I think it's actually April 26th.
The 26th. I guess that's something we could talk about. Sarah's in the room. We'll talk about that today. We've been gearing up for pinwheels. We've been gearing up for Mental Health Awareness Month. We will definitely talk about that.
This is Elizabeth Kopp with Girl Scouts Virginia Skyline. I just popped some information in the chat log. We have a Discover Girl Scout night on Friday, May 30th in Halifax in South Boston. I actually literally just confirmed this morning before this meeting, so there's no flyer or Facebook event posted yet, but we'll have information in the coming weeks on that. And we are extending free membership for new girls and new troop co-leaders to join right now. And that is also extended to pre-K rising kindergartners starting April 1st. So girls going to kindergarten next year can already join on starting April 1st. So that's exciting information. Thanks.
Awesome. Thank you, Elizabeth. I've got your information in the chat. I have Elena's information in the chat. Thank you all so very much. We will definitely share that information out. One additional item that you all may have already been contacted about is we are in our year cycle to We are required to reach out to each of you individually to complete what you see on the screen. My staff is reaching out to you now in the last couple of days and in the coming weeks. We are required every 2 years as part of the funding for the coalition to complete the coalition readiness and effectiveness assessment. I think so far, I believe about 10 members have completed it. We are gearing up to getting at least 50, 60 members, supporters of the coalition to complete this by mid-June is our deadline. I'm sharing on the screen now in case you can capture that bit link. It's going to take you to a survey of our coalition, how well you believe we are working together, how effective we are at accomplishing goals and tasks, and you get a gift card sent to you immediately. Folks here have been doing a great job getting that back to folks right away. So please look out for that. It was in our monthly newsletter. It is not on social media because we're only asking the folks that are active on coalition meetings and events to participate, right? The state is interested to know those of you involved with the coalition, supporting the coalition, leadership team members, folks who support the efforts that the coalition is making in completing this. And as I shared the last leadership team meeting, we had 120 individual people who attended our meetings over the last 2 years. So we're reaching out to all of those folks from 23 and 24, and also reaching out to anyone who is active in the coalition. Any questions about that? I hope everybody recognizes that. If you don't, please let me know so I can make sure Jenna sends you a copy of the link to fill that out for us.
Kenan, before we go,
Yes,
can I bring something to the attention of everyone in the meeting?
absolutely.
Will you please pull up the trauma-informed conference flyer again, please?
Yes. Oh, my fingers crossed for that. Hang on.
Okay.
You may have to go grab it again.
Sarah's chuckling in the room about my ability to, hang on 1 second. I know I have it. I know I have it.
Yeah.
Hang on. There it is. There it is.
I'm sorry, I probably should have warned you.
No, you're fine. Look, I'm rolling it. I'm rolling it. The magic is rolling. Hang on.
Okay.
It's going. There it is. Look at me. Look at me. Hey. Yes, absolutely. Yes, please.
Okay, everybody, and please believe me, I've already had this conversation with the folks that's putting on this event, but I wanted to share this little piece of information with you. I know it's not popular right now to talk about representation and talk about diversity, but please be aware of what your communication, what messages it sends to people when you send it out. And I just want you all to just look at that particular flyer and tell me what's missing. Does anybody realize what's missing?
People of color.
Yeah.
Right. There are no people of color on that particular picture. So what type of message does that send to the community? And what type of things are people supposed to realize and supposed to think? And I know in the climate that we're living in right now, that's not the most popular thing to talk about, and it's not the most popular thing that we can harp upon. But even if we can't address it through our words and address it through whatever channels, that we used to, we still have to keep these things into consideration because representation matters. And if people don't see themselves in things that we do, there may be a tendency to not take advantage of it, or they may not participate in it. So please be careful in the messages that you send. And I just wanted to share that with everybody. And like I said, I wanted to let you know, I've already talked with the folks that are putting this on and just letting them know what I saw as soon as the flyer was presented to me.
Right, right.
So thank you.
Thank you.
All right, other announcements? All right, we had a good meeting today. All right, very nice. No further announcements? All right, I'll call the adjournment at 11:29. You all have a wonderful day. Oh, Amber said happy first day of spring, everyone. Yeah, same to you. Thank you all. I'll stop the recording and save the chat. You all have a wonderful day. And again, yeah, happy first day of spring.
Thanks, Kenan. Thanks, everybody.
Thank you. Y'all have a good day.
Thank you. Have a good one.
Sarah and I have a lot of cake to eat.
Enjoy the cake.
Come see me next time. Let's see, stop the recording. There we go.
Sylvia wants some of the cake. I'll message her.
All right, hang on, I gotta save the chat box. I can't shut down the meeting until I save the chat box. It's always like a struggle. Where is that chat box at? There you go. It's funny, ever since Zoom updated and my Windows on my new laptop went to Windows 11, it's like I feel like I'm in an alternative universe. Let me see, where's the chat? Oh, hang on.
I think it's top right.
I know, why move things around?
There you go.
All right, save chat, there it is. All right, now, wait a minute. Now I have to go to this downloadable file. Hang
You
on.
can click that show in folder right there.
Where do you see that?
At the bottom of the
Oh,
chat.
there it is, there it is. You're right, okay. There we go. And I have to save that because I don't save. I'll open it up, I want to copy it. Copy. Hey.
She sent me the message. Cake.
Why is it saying copy as tab? It should say, oh, copy, there it is, copy. I'm saving this thing, I don't want it to shut down. Hang on. Gosh dang. Hang on, where did my folder go? Ah, hang on, let's see what this does, hang on. Wait a second.
I'm gonna take out the piece too.
Please do, please do.
Otherwise I gotta eat the rest, so take it. Take as much as you want.
Copy here, paste it here.
I'll take her a big piece.
Hang
if she
on,
needs it.
oh, why is it opaque?
Yeah, she really does.
Paste, hey, I got it,
Thanks,
okay, it's
Kevin. We'll see
inside
you in a
my,
while.
all right, it's inside my March meetings, okay, good, all right, perfect.